All right, so we talked about Wolff-Chaikoff effect, which is basically when you have lots of iodine, it inhibits the release of thyroid hormone, right? Well, this is the exact opposite. When a patient is iodine depleted, so he has to be iodine depleted, and then you give him iodine, the thyroid gland basically goes rogue and it takes all that iodine and stimulate the thyroid release. Or if the patient had any toxic multinodular goiter that are, they are different from the thyroid tissue, they will also take that iodine and will release they release the thyroid hormones, leading to hyperthyroidism. So it occurs when a patient with iodine deficiency or partially autonomous thyroid tissue, things like nodule, right, toxic multinodular goiter, becomes iodine replete. So you basically give him iodine or any drug that's contains iodine, any contrast agent that contains iodine. This could lead to hyperthyroidism, and this is called Jod-Basedow phenomena. The phenomena that when you give iodine to a patient that's iodine depleted, or he has a thyroid tissue that's rogue, it takes that iodine and leads to hyperthyroidism. Because the normal thyroid gland, when it takes excess iodine, it will shut down the thyroid synthesis, not lead to hyperthyroidism. So unlike the Wolff-Chaikoff effect, which refers to the transient inhibition of the thyroid hormone synthesis in response to high iodine load, the Jod-Basedow phenomena is the opposite. In the Jod-Basedow phenomena, the sudden influx of iodine leads to the increased production and release of thyroid hormone, leading to hyperthyroidism. So let's see how it presents on the board exams, the Jod-Basedow phenomena. So a 52-year-old female with long-standing history of multinodular goiter presents to her endocrinologist complaining of recent palpitation, weight loss, and heat intolerance. So she complains of hyperthyroidism. On examination, she has diffusely enlarged thyroid glands without any nodules. Laboratory investigation reveal elevated levels of serum free T4, T3, and TSH. She reports a history of long-term iodine supplementation for iodine deficiency. Which of the following is the most likely diagnosis of her current presentation? So since she was deficient of iodine and she's taking iodine supplementation, this will lead to increased thyroid hormone synthesis by these multinodular or the nodules of the thyroid that are autonomous from the entire thyroid gland. So this will lead to Jod-Basedow phenomena. Another case is a 40-year-old male with a history of amiodarone, taking amiodarone. As you guys know, amiodarone is an anti-arrhythmic drug, but it also has iodine because amiodarone is iodine. Okay, it has iodine. So he's taking iodine and he has diffusely enlarged thyroid gland with hot nodules. So he has already nodules that could take that iodine and make lots of thyroid hormone. And this is exactly what happened. So which of the following is the most likely cause of hyperthyroidism? It's probably Jod-Basedow phenomena that led to these toxic nodules making even more thyroid hormone, and it even lead to more hormone that it could lead to thyroid storm. Another case, a 60-year-old male with a history of chronic iodine deficiency presents to the clinic with symptoms of weight loss, irritability, and palpitations. So he has iodine deficiency and he has hyperthyroidism. On examination, his thyroid gland is diffusely enlarged without any nodules. Laboratory investigations reveal elevated levels of T3, T4, and suppressed levels of TSH. He resides in a region known for iodine deficiency, so he started taking iodine supplementation. So he was deficient and he started taking iodine supplementation, and then he presented with hyperthyroidism. So this is also Jod-Basedow phenomena. So what is goiter? Goiter is enlargement of the thyroid gland. And it could be diffuse or smooth. Right? It could be diffuse or smooth. So diffuse means completely enlarged. The whole gland is enlarged. And this happens whenever you have, so I draw a picture here. So this is a small normal gland. It becomes goiterous, so it becomes larger. And this happens usually by the effect of TSH and TSIs, or thyroid stimulating immunoglobulins, right? These stimulate the thyroid gland to hypertrophy and hyperplasia, right? Undergo hyperplasia. So you get diffuse enlargement, right? But you could get, multinodular. You could, instead of diffuse, you get nodular goiter. So some nodules become enlarged and the rest of the tissue doesn't change. or just, a little bit of enlargements, like an adenoma or cancerous cyst. Okay, so these are the three different causes of or types of goiter. Are you guys here? Okay, hypothyroidism. Also gynecomastia, because of the effect of thyroid hormone on the breast tissue. If it's very high, it could lead to breast tissue proliferation. Okay. So hyperthyroidism leads to decreased LDL, not increased LDL, and basically increases the burning of fat and lipids. Okay, also increased TSH and increased LDL, HDL, and total cholesterol. All three are right. Okay. Yeah, the most common cause is Hashimoto in in developed countries. Okay. This occurs in Graves, not in. Okay, subacute granulomatous thyroiditis. Okay, let's see this case. 55-year-old male presents to his primary care physician with complaints of solely enlarging mass. He denies any symptoms of hyperthyroidism or hypothyroidism. On examination, there is palpable firm nodule in the right lobe. Yeah, that's step 2 question. Yeah, about it. Thyroid cancer. So basically, thyroid cancer presents as a nodule, right? And then we use fine needle aspiration to see whether this nodule is an adenoma or a cancer or carcinoma. The main treatment is basically to remove the thyroid gland, and we monitor and follow up after thyroidectomy to make sure that everything is going fine and the tumor is not going back. So when you remove the thyroid, you have some complications because you have, vasculature and you have nerve supply just beside the thyroid. And you have parathyroid glands inside the thyroid, so you could remove any of them, right? So for example, when you are trying to ligate this artery in order to remove the thyroid gland, you ligate the superior thyroid artery. You could ligate or damage the superior laryngeal nerve, specifically the external branch of it that goes side by side with the superior thyroid artery. Or if you're trying to ligate the inferior thyroid artery, you could basically damage the recurrent laryngeal nerve. It's called recurrent because it goes down and then goes back up. So you could damage the recurrent laryngeal nerve or the external laryngeal nerve. So you could get any symptoms of hoarseness or anything like that after surgery. And you should know that if you get these symptoms, you might have done some damage to one of these nerves. And also, you could remove the parathyroid glands, when you're trying to remove the thyroid gland. So this will lead to hypocalcemia after surgery. So let's see a case. All right, so this is the thyroid tissue. So you have follicular cells right here. And you also have C cells. So if the cancer arises from the follicular cells, you have two types. You have follicular carcinoma and you have papillary. You have papillary and you have follicular. But if it arises from the C cells of the tissue, the thyroid tissue, it's called medullary, or the medulla, because it's the medulla inside. Okay. Papillary carcinoma is the most common type of thyroid cancer. And the way we know it's papillary carcinoma and not any other tumor is by taking a fine needle aspiration biopsy, and we'll look under the microscope for different characteristics. And there is something called orphan Annie eye, and this is orphan Annie. There is a clearing in the middle, so it explains the nuclei of the papillary thyroid carcinoma, as you see here. It's nuclei with central clearing. Okay, this is how it's described in the question. Nuclei with central clearing. This is one of the characteristics, in addition, of course, to the arrangement of the cells in the form of papillae, as you see here. These are the papillae. So this is papillary thyroid carcinoma. So instead of being like follicles like that, they arrange in a papillary formation. So this is papillary carcinoma. also you could have something called seminoma bodies. The way I remember is P for P seminoma for papillary carcinoma. So seminoma bodies is, you know, these worldly appearing bodies, basically collagen deposition. And you also have nuclear grooves, which is basically, as you see, if you can see this nucleus here, there's a groove in the middle. So basically, you have to know these characteristics of the papillary carcinoma in order to be able to diagnose it on the question. So what is the trigger of papillary carcinoma? It's a mutation in the RET, or the papillary thyroid carcinoma rearrangements, or BRAF mutation. It's high yield to know these two, RET and BRAF. And the reason, the trigger of the trigger is the irradiation. So childhood irradiation, let's say you're trying to treat another cancer, and by the way you hit the thyroid gland with this radiation, it could damage the DNA and lead to these mutations. And these mutations will drive the growth of the follicular cells to form the papillae, right, which have these characteristics, histological characteristics, basically. And follicular and papillary carcinoma have a good prognosis because when you remove the gland, most likely it's just that and it's cured. Survival rates are like 95-91%. Like I said, papillary thyroid carcinoma is the most common type. Okay, you should know that. Let's see this case. 45-year-old female presents to her doctor with a palpable neck mass that she recently noticed. So that's how it presents. Thyroid cancer presents as a palpable neck mass. She denies any symptoms of hyper or hypothyroidism. It doesn't have any secretions. It's non-functional. On examination, there is a single firm nodule in the right lobe of the thyroid gland. Laboratory investigations reveal normal levels of serum free T4, T3, and TSH. Fine needle aspiration, as you see here, this is how we diagnose it, of the thyroid nodule reveals the presence of irregular nuclear features, which is, you know, any cancer has these, including nuclear grooves, very specific to papillary carcinoma, like I said, and nuclei with central clearing. So which is the most likely diagnosis? Papillary carcinoma. Follicular carcinoma also has a good prognosis, but instead of the cells of the thyroid form a papilla, they form a follicle like that, just like the tissue, the thyroid tissue. It looks like the thyroid tissue. And in fact, fine needle aspiration doesn't help us distinguish between the follicular carcinoma and adenoma because it doesn't show whether you have capsular invasion or not, because any benign tumor has a capsule. Okay, so usually this capsule, you know, it's normally here. So if it's benign tumor, it will remain inside the capsule. If it's malignant, it will cross the capsule. As you see here, if this is the capsule, there is some invasion of the cells outside. So this is follicular carcinoma. And the difference is this is follicular adenoma. There's intact capsule here, right? And they look like follicles exactly, just like the normal tissue. So what is the trigger? It's also radiation. When you think about thyroid cancer, think radiation usually is the trigger. And instead of BRAF and RET mutations in papillary carcinoma, here we have RAS mutations and PAX8 PPAR gamma translocations. Fine needle aspiration, you have to know this, may not provide a definitive distinction between follicular adenoma and carcinoma. So you have to get another investigation or evaluation, usually an excisional biopsy. So let's see here. This case, 40-year-old male presents to his doctor with a painless, slowly enlarging neck mass. Okay, painless, enlarging neck mass. He denies any symptoms of hypothyroidism. On examination, there is a firm, non-tender nodule in the left lobe of the thyroid gland. Laboratory investigations reveal normal levels of serum-free thyroxine, T3, T4, and TSH. Fine needle aspiration biopsy reveals follicular cells with minimal nuclear atypia, absence of nuclear grooves, and or pseudo-inclusions. That tells us that it's not papillary carcinoma, and evidence of capsular and vascular invasion. So this is follicular carcinoma.
Doctor, please, if you can go back for the case. So this means if he didn't tell us follicular cell, we can't differentiate between papillary and follicular.
Yeah, right.
I mean, in the question.
Oh, yeah. So you're right. Nice catch. I haven't noticed this. Yeah, you shouldn't. Yeah, sometimes you're able to do it. Like, it's not always, but sometimes. Like here, it's a very nice catch of you, but it sometimes leads to, you could see that there are some capsule invasion, but some other times it doesn't. Because when you're taking... Sorry?
Yes. Who is the worst? Who is the better prognosis?
Both have good prognosis. Both papillary and follicular have good prognosis. The bad one is anaplastic. We'll talk about it.
Okay, but I see incidence 80%. Oh, there's incidence. Okay.
Yeah,
there's number big.
Yeah, the incidence is the the cases of all cases of thyroid cancer. What percentage is papillary thyroid cancer and what percentage is follicular thyroid cancer?
Okay, thank you. Doctor, just the last question.
Yeah.
So, in the histology, papillary and follicular is invasive? I mean, capsule or no?
Yeah.
Papillary, there is some body.
Yeah.
Follicular, there is no some body.
Exactly.
Okay.
And orphan Annie nuclei.
With some body.
Yes. Okay. Now medullary carcinoma, which arises from the C cells, right? It doesn't have anything to do with the follicular cells. Now it arises from the C cells. And it's pretty easy because, it has an amyloid stroma, amyloid that's made up of the calcitonin, because C cells secrete calcitonin. So the cancerous cells also secrete calcitonin, and it accumulates as amyloid, and it stains positive with Congo red, right? Pretty easy medullary carcinoma. It's associated with MEN2, MEN2A and B. I'll talk about that at the end. Let's see this case. 50-year-old female presents to her primary care physician with a papillary neck mass that she recently noticed, so it's probably thyroid cancer or adenoma, so we have to know. She denies any symptoms of hyperthyroidism or hypothyroidism. On examination, there is a firm, non-tender nodule in the central region of the thyroid gland. Laboratory investigations reveal normal levels of serum free T4 and T3 and thyroid-stimulating hormone. Finally, aspiration biopsy reveals presence of sheet of polygonal cells with abundant eosinophilic cytoplasm. Eosinophilic cytoplasm because of the calcitonin staining and central nuclei. He didn't say anything about central clearing. Additionally, immunohistochemical staining shows positive staining for calcitonin. So this is medullary carcinoma of the thyroid. The last one is undifferentiated or anaplastic carcinoma. Okay, so it could arise from any cell in the tissue, but it's undifferentiated. So it doesn't look like follicular cells. It doesn't look like C cells, any cells in the tissue. So it's undifferentiated, and it's very rapidly growing, right? It grows very rapidly. And it's associated with compressive symptoms because when it grows rapidly, it can go to the trachea, to the esophagus, leading to dyspnea, dysphagia, and hoarseness, right? It can grow backwards. And it has very poor prognosis since it's very rapid, large, so it can metastasize easily. And it's the most aggressive form of thyroid cancer, just like small cell carcinoma of the lungs. And what mutation is associated with? TP53, which is the policeman of the cell, right? Let's see this case. 65-year-old female presents to her primary care physician with a rapidly enlarging neck mass associated with dysphagia and hoarseness. On examination, there is a large fixed hard mass, involving the entire thyroid gland. Normal levels of T3, T4, thyroid-stimulating hormone. Final aspiration reveals undifferentiated cells with pleomorphic nuclei, frequent mitotic figures, which is associated with any type of cancer in any cell, and areas of necrosis. Immunohistochemical staining, negative for thyroglobulin, and whatever. Which of the following is the most likely diagnosis? This is anaplastic carcinoma of the thyroid. Okay, so let's talk about parathyroid diseases. So we finished the thyroid gland. Now we'll talk about the parathyroid. So we have hyperparathyroidism and we have hypoparathyroidism. Hyperparathyroidism means we have increased levels of parathyroid hormone in the blood. Hypo means we have decreased parathyroid hormone. Let's start with hypo because it's easier, right? So we just talked about thyroidectomy. We could just remove the thyroid gland along with the parathyroid hormones. Glands, right? So after thyroid surgery, you could remove the parathyroid glands so they're not able to release parathyroid hormone, so you get hypoparathyroidism. Autoimmune destruction of parathyroid gland, it's a part of a big syndrome. It's called autoimmune polyendocrine syndrome type 1, which is a big name, APS, right? It's basically autoimmune destruction of multiple glands. One of them is parathyroid gland. Or you could have developmental anomaly that completely didn't develop the parathyroid glands, like DiGeorge syndrome. Let me talk about DiGeorge syndrome quickly here. So if you see, these are the pharyngeal arches, basically the pouches of the endoderm that we talked about, and the ectoderm that is located in the neck. If you see the third and fourth pharyngeal pouches, these are basically absent in patients with DiGeorge syndrome. And the way I like to remember die 2, DiGeorge syndrome, so you have 2 pouches missing, third and fourth pharyngeal pouch, okay? And third and fourth, if you guys remember fourth pharyngeal pouch, it gives rise to the ultimobranchial body, and third pharyngeal pouch, right? So the third pharyngeal pouch gives rise to the inferior parathyroid because it's 3, it's the lower number, and the fourth pharyngeal pouch gives rise to the superior parathyroid gland, if you guys remember. And the ultimobranchial body, if you guys remember, gives rise to the C cells of the thyroid gland. And all these associate with the thyroid diverticulum, which comes down from the tongue, and they both stay in the neck to form the thyroid gland, right? And yeah, by the way, it's a deletion, 22q11 deletion, basically chromosome 22. The little piece is missing in DiGeorge syndrome. That's the cause. And this piece is important in development of third and fourth pharyngeal pouches. So basically, when you have missing third and fourth pharyngeal pouches, you get missing parathyroid glands, so you get hypoparathyroidism. What are the symptoms? So parathyroid hormone, the main effect is to increase the calcium levels and decrease the phosphate levels. So you have the opposite. Hypoparathyroidism, you have hypocalcemia because there is no parathyroid gland to increase the reabsorption of calcium and increase the resorption of bone to release calcium. So you get hypocalcemia. You get tetany because of the hypocalcemia, and you get hyperphosphatemia, or high levels of phosphate. Tetany, the 2 most important signs are Chvostek sign, which is basically when you tap on the facial nerve here, you get contraction of the muscles surrounding the eyes. And Trousseau sign, when you use the cuff, the blood pressure cuff, you get spasm of the palms here, or the fingers. Okay, it's called Trousseau sign. See this case, a 42-year-old female undergoes total thyroidectomy for papillary carcinoma of the thyroid. 4 days post-operatively, she complains of numbness and tingling in her fingertips and muscle spasms in her hands. On examination, her Chvostek and Trousseau signs are positive. Laboratory findings shows hypocalcemia and increased serum phosphate levels. Which of the following is the most likely diagnosis? It's hypoparathyroidism, because when you remove the thyroid, you also removed the parathyroid glands. A 3-month-old infant presents with recurrent respiratory tract infections, feeding difficulties, failure to thrive. Physical examination reveals a small chin, low-set ears, wide-set eyes. Cardiac examination reveals a loud systolic murmur. Laboratory investigations shows hypocalcemia. What is the most likely diagnosis? Can you guys say? I want you to say what is the most likely diagnosis here. DiGeorge, right? Because also DiGeorge have a developmental anomaly of the thymus. Okay, because the thymus, comes from the third pharyngeal pouch as well. As you see here, this is the thymus. and also the parathyroid glands. And the thymus is important for T cell development. So when you have T cell damage or developmental problem, you have recurrent infections, and you also have cardiac problems because they also share in some of the heart features. So you get cardiac anomalies. So parathyroid glands, thymus, heart, and immune system.
The thymus will be absent, correct, Dr. Yassin?
What is?
The thymus absent?
Absent, yes.
Mm-hmm.
The thymic shadow will not be there.
Dr. George, it will be within 3 months or 6 months in the life?
Yes, yeah.
And it's congenital almost.
Yeah, congenital, yeah.
And it will be accompanied by low immunoglobulin because thymus or immunodeficiency.
Right.
Okay.
What about pseudo-hypoparathyroidism? So pseudo means lying, right? It's lying hypoparathyroidism. So we see the symptoms. It says it's hypoparathyroidism, right? We see the patient. He has hypocalcemia, hyperphosphatemia, but the parathyroid levels are actually high, right? So he has low calcium and high phosphate, but there's high parathyroid hormone levels. So why is that? The problem is there is a mutation in the parathyroid hormone receptor, actually the G protein, the alpha receptor, or the alpha part of the G protein subunit, alpha subunit. So this is responsible for the signaling of parathyroid hormone. That means it's not working. It's resistant, right? So the body tries to compensate by increasing the levels of parathyroid hormone. So you get high levels of parathyroid hormone, but it doesn't work. So you get low calcium, high phosphate. So it's called pseudo-hypoparathyroidism. Okay, so it's GNAS1 gene, and GNAS is basically G protein alpha subunit. Okay, G protein alpha subunit, GNAS. And the thing is also growth hormone is associated with this same receptor or same protein. So you also get the GNAS mutation. It also affects the growth hormone and growth hormone releasing hormone. So you get also some growth developmental problems in this patient. Okay, so the trigger here is a mutation in the GNAS1 inactivating receptor or subunit that leads to decreased signaling of the growth hormone and the parathyroid hormone, right? So you get high levels of parathyroid hormone, resistance of parathyroid hormone effects in kidney and bone. So you get low calcium and high phosphate, right? So how does the patient looks like? So pseudo-hypoparathyroidism, basically it's associated with shortened fourth and fifth digit because you don't have growth hormone to make them larger. It's not as simple as that, of course, but this is how I remember it. Short stature because you don't have growth hormone. Round face because you don't have the growth of the mandible, proper growth of the mandible. And developmental delay. Subcutaneous calcifications. Developmental delay also because of the growth hormone. In addition to these symptoms, you have elevated parathyroid hormone, decreased calcium, and increased phosphate. Very important. I want you to focus on this because there is pseudo-hypoparathyroidism. Okay, so I'll take your time to remember that you have a mutation in the alpha subunit of the G protein of parathyroid hormone and growth hormone. So it doesn't work. You get low calcium and high phosphate. What about pseudo-hypoparathyroidism? So unlike pseudo-hypoparathyroidism, there is no end organ resistance to parathyroid hormone due to a normal maternal allele maintaining renal responsiveness to parathyroid hormone. So you still have just the paternally transmitted mutations in GNAS, but you still have another gene that's normal that maintains the function of the parathyroid hormone. So it has an effect on the growth hormone, but it doesn't have an effect on parathyroid hormone. So it's pseudo-hypoparathyroidism. So means it's lying pseudo-hypoparathyroidism. If you remember, this is pseudo-hypoparathyroidism, right? Decreased, shortened fourth and fifth digit, and round face, and obese and short, right? This is pseudo-hypoparathyroidism because of the effect of growth hormone. So pseudo-hypoparathyroidism means, you know, he looks like pseudo-hypoparathyroidism, but it's not pseudo-hypoparathyroidism, right? Because there is no decrease in calcium and there is no increase in phosphate, because the parathyroid hormone is still working, because it's just a mutation in the paternally transmitted gene. So let's see two cases to differentiate between the two. So one has abnormal. So actually, both diseases have the same shape here, same clinical picture of growth hormone deficiency, but one has parathyroid hormone problem and the other doesn't have it. Okay. So let's see these two cases here. A 10-year-old boy presents with short stature, round face, and obesity. Physical examination reveals brachydactyly. Laboratory findings shows hypocalcemia, increased serum phosphate levels. Parathyroid hormone levels are elevated. Which of the following is the most likely diagnosis in this patient? What do you think? Is it pseudo-hyperparathyroidism or pseudo-hypoparathyroidism? The one we talked about is type 1. Pseudo-hypoparathyroidism, right? Because you have parathyroid hormone levels are elevated, and hypocalcemia and increased phosphate levels.
Pseudo. So
there's A and B. Which one?
1A.
I wanted to ask if the electrolyte disturbance are presenting like secondary hypoparathyroidism.
Yes, exactly. Let's see this one. 25-year-old female presents with short stature, brachydactyly, and obesity. Same symptoms. Physical or same signs. Physical examination reveals no other notable abnormalities. Laboratory findings show normal calcium and phosphate levels. So he looks like pseudo-hypoparathyroidism, but he's pseudo-hypoparathyroidism. So this is the diagnosis. Okay, good job. Okay, very tender thyroid is the subacute granulomatous thyroiditis, which is decurve vein. Slowly enlarging one is the Rydell's. Yeah, this also could be. Yeah, this is also Rydell's. So these two answers are right. Okay, the potential complication is this. Rydell thyroiditis, it's not complication. These are not complications. these are associated findings with Rydell's. So Rydell sometimes is a part of, a systemic condition that leads to fibrosis, retroperitoneal fibrosis, and autoimmune pancreatitis, and non-infectious aortitis. Yes, but this is not a complication. This is an association. This is a complication. And sometimes patients with Rydell's are afraid that this is, doctors are afraid that this is anaplastic carcinoma. Good job. I'm so glad that you guys got this. Absence of capsular or vascular invasion. This is thyroid adenoma. Yeah, the thyroid adenoma, the most common histology of, if it's adenoma, not carcinoma, it's that it comes from the follicles. So it looks like follicles. if it leads to hyperthyroidism. Okay. Okay. It could lead to lymphoma, like we said. It's not thyroid cancer though, so I don't know why you picked thyroid storm. It leads to decreased levels of thyroid hormones, not increased. Okay, the most common cause is Graves. Okay, so a thyroid adenoma is basically instead of being cancer, it's adenoma. So it means one cell started to divide, right? Just one cell. So it's a neoplasm, but it's benign and solitary. And it could be cold nodule or hot nodule, and these expressions refer to the uptake of iodine by the cells. Most thyroid adenoma are cold actually, and they don't take iodine. That means they don't actively take iodine, so they don't release thyroid hormones. Hot nodules means they take iodine, and they could release thyroid nodules. The most common histological type of thyroid adenoma is follicular, like we said. Unlike follicular carcinoma, thyroid adenomas do not show capsular or vascular invasion. Okay, so we have three types of hyperparathyroidism. We just finished talking about hypoparathyroidism, and we said there is a hypoparathyroidism. You might remove the gland completely while doing thyroid surgery, or you could have autoimmune destruction of the parathyroid glands, or you could have DeGeorge syndrome, which you don't have development of the parathyroids at all. In hyperparathyroidism, it could be primary, it could be secondary, or tertiary. So what is the difference? Primary means there is secretion, direct secretion of the parathyroid hormone without any reason or cause, right? It's just because they lost the control, right? They lost control, and they get hyperplasia, or they got an adenoma, right? So an adenoma that's, it doesn't care about anything. It's just continuously secrete parathyroid hormone without any reason, okay? And this is primary. Secondary, it has a reason. It's secondary to something, right? And it's usually secondary to hypocalcemia, because that's the normal release of parathyroid hormone. It's secondary to hypocalcemia. When the calcium sensing receptors feel that there is low calcium, the parathyroid glands release parathyroid hormone, right? The tertiary is basically happens after secondary, right? So you have continuous, or there is persistent hypocalcemia, right? So there's persistent hypocalcemia. there is persistent hypocalcemia that led the glands to become hyperplastic, right? The consistent hypocalcemia or the persistent hypocalcemia led these glands to become hyperplastic, and then they become autonomous, just like primary, and they continuously secrete parathyroid hormone. So can you see the three differences now? So let's read. So primary hyperparathyroidism, it's usually caused by adenoma or hyperplasia. So what's the difference between adenoma and hyperplasia? Adenoma is just, one parathyroid gland developed an adenoma. But hyperplasia means all the 4 glands develop, kept dividing, and they are hyperplastic now. Okay, so they keep releasing parathyroid hormone for no reason, right? So you get hypercalcemia and hypercalciuria, and you get all the symptoms of that, right? And you get hypophosphatemia as well, right? You get elevated PTH levels and increased urinary CAMP levels. This is important because if you have high levels of PTH, that means you have increased function of the receptor of parathyroid hormone, leading to cyclic AMP levels are high. So what are the symptoms of hyperparathyroidism? It's the symptoms of hypercalcemia and hypophosphatemia, right? Which is bone pain, weakness, constipation, flank pain because of kidney stones, or abdominal pain because of acute pancreatitis. High levels of calcium are a cause for acute pancreatitis, if you guys remember, just like increased triglyceride levels. It's one of the important causes of acute pancreatitis, hypercalcemia. And neuropsychiatric disturbances because it affects the brain, so psychiatric overtones. So stones, thrones, bones, groans, and psychiatric overtones. Also, because the parathyroid is important in bone resorption, it could lead to these empty spaces of the bone. It's called ostitis fibrosa cystica. It's complication characterized by cystic bone spaces, see here. They are known as brown tumors, which is like a misnomer, it's not a tumor. It results from elevated PTH levels and is classically associated with primary hyperparathyroidism, although it can also occur in secondary hyperparathyroidism. It results from elevated PTH, right? It doesn't matter, primary, secondary, tertiary, it will still be there, okay? And remember, primary means adenoma or hyperplasia. Remember, adenoma or hyperplasia. Secondary, there is a reason, right? Let's read this first. 45-year-old woman presents with fatigue, generalized bone pain, recurrent kidney stones. These are symptoms of hypercalcemia. Laboratory findings show hypercalcemia, increased serum parathyroid hormone, and normal renal function. Imaging studies reveal symmetric enlargement of all 4 parathyroid glands. Okay, it doesn't have any reason why these glands are enlarged like that, right? So it's primary. Which of the following is the most underlying cause? Primary hyperparathyroidism because of the parathyroid hyperplasia. See this 58-year-old man presents with fatigue and constipation, generalized bone pain, symptoms of hypercalcemia. Laboratory findings shows hypercalcemia and increased serum parathyroid hormone levels. Imaging studies reveal a single enlarged parathyroid gland, single enlarged, so this is adenoma. Final aspiration cytology of the gland shows adenomatous cells. Which of the following is the most likely underlying cause of this symptoms? Parathyroid adenoma. This is the cause, right? Or primary hyperparathyroidism, not secondary. So what is secondary? Secondary, there is a cause behind that. And the most important cause of hypocalcemia is kidney failure, right? The kidneys are important activator of vitamin D. And vitamin D activates the increases absorption of calcium and phosphate from the intestines. So when you get low vitamin D levels, you get decreased level of calcium, and it's persistent, so it will always be there. So the secondary effect is the release of parathyroid hormone. So let's say that the patient continuously get progressive renal failure, like the kidneys became worse. So there will be persistent low calcium. This will lead the parathyroid glands to become hyperplastic and become autonomous, right? they go rogue because there's persistent hypocalcemia. Now it's called tertiary when they go rogue. Okay. Before that, if it's a normal response to hypocalcemia, this is called secondary. If they go rogue because of persistent hypocalcemia, then it's tertiary. So let's read here. Secondary hyperparathyroidism causes often seen in chronic kidney failure, results from decreased calcium levels and increased phosphate level. By the way, high phosphate is an important finding in kidney failure patients, as we have taken in renal section. So decreased calcium and increased phosphate are two important findings in renal failure, right? Because the kidneys cannot excrete phosphate, right? So you get increased phosphate levels, which even like increased phosphate levels are important stimulator of parathyroid hormone. So you have two reasons why there is secondary hyperparathyroidism, because you have decreased calcium and increased phosphate. Okay. So what happens? CKD, inability to activate vitamin D, so you get hypocalcemia, and inability to get excrete phosphate, so you get hyperphosphatemia. Both hypocalcemia and hyperphosphatemia in CKD lead to hyperparathyroidism. In contrast to other causes, chronic kidney disease typically presents with hyperphosphatemia rather than hypophosphatemia, right? Because the parathyroid hormone increases excretion of phosphate, but since we cannot excrete phosphate here, you present with hyperphosphatemia, right? So you get decreased calcium and you get increased phosphate. This is the stimulators of the parathyroid hormone here release. So let's read this. A 60-year-old woman with chronic kidney disease presents with bone pain, muscle weakness. Laboratory findings show hypocalcemia, elevated serum phosphate levels. That's why of the elevated serum phosphate levels and increased serum parathyroid hormone levels. Imaging studies reveal diffuse bone demineralization. That means there's that's because of the high levels of parathyroid hormone. Which of the following is the most likely underlying cause of her symptoms? The most likely underlying cause is increased serum parathyroid hormone. The question here, what caused the increased serum parathyroid hormone levels, is the chronic kidney disease that led to hypocalcemia and increased phosphate levels. Okay, so this is called secondary hyperparathyroidism. So let's see tertiary. I think there is another case here. A 45-year-old woman with end-stage renal disease has been on long-term dialysis. Laboratory findings shows persistent hypercalcemia, hypophosphatemia, and increased serum parathyroid hormone levels. As you see here, secondary hyperparathyroidism, you still have hypocalcemia, but because here the parathyroid glands went rogue, they have increased very, very high levels of parathyroid hormone that led to hypercalcemia and hypophosphatemia, and increased in, Imaging studies reveal all 4 parathyroid glands are enlarged because of the effect of tertiary hyperparathyroidism. Which of the following is the most likely underlying cause? This is tertiary hyperparathyroidism because of the hyperplasia, the rogue, the going rogue of the glands. So let's see here. So renal